Then it can be associated with spina bifida, it can be occulta, just like we have few cases where there are telltale signs. And these can be meningoceles with the covering of meninges, or they can be meningomyelocele containing the neural tissue as well. So these are associated with congenital anomalies in congenital type of scoliosis. Then tumors can cause scoliosis at times. These can be extradural tumors, these can be metastatic as well, or intradural tumors, both types. Intradural extramedullary and intradural intramedullary tumors. They can have compressive effects and cause scoliosis in these patients. Intramedullary tumors are notorious for causing these problems. They can be astrocytomas, ependymomas, or hemangioblastomas. I'll give you lying anterior to the C1-C2 area. So what we did was we opened it up and we did it anteriorly. We got removed from right side, and then we went posteriorly and stabilized it. So neuromonitoring here is very important again. We should not lose any signal. You can see the tumor has been debulked from here. There can be low-lying tumors as well, like here we can see at C71 area. Stabilization with domino rods is required. We can fix it in the upper thoracic as well as the low cervical area, but we need to put in dominoes because the size of the screws up there and low down, it's different sizes. Then we can have intradural tumors that can be extramedullary or intramedullary. A few examples of these intramedullary tumors, and this one was something extramedullary. What we do is we go for, after neuromonitoring a patient, putting the patient prone, we go for durotomy. We dissect out the tumor, and here we can see the dura has been retracted on both sides, and then we take out the tumor, and once it is cleared, then we repair the dura. This is an example of intramedullary tumor. It is extending from the upper cervical area. Normally in these cases we can't take it out. So what we go for a myelotomy and get a biopsy done, and then we go for radiotherapy, conservative treatment. This is one example. Ependymomas, they are at the terminal part of this where the chorda equina is being originated. They are mostly central. Problem of urination, and the vital centers are there, so we have to be careful by taking them out. Thank you. Any questions from your side?
So is there any role of mini access surgery to remove the tumors?
देखिए एक चीज याद रखें, आपका गोल क्या है? If your goal is to take out the tumor as a whole and you need to take it out, then minimal access surgery or open surgery, that is not an option. Taking out the tumor as a whole is your goal. So I think so primary goal should be the first thing. Just like in infection, debridement is the first goal. Here the tumor excision is the first goal. So you should not be worried about taking them out the minimally access or by open technique. So I think so they should be removed by a technique which you are well conversant and it is safe for the patient. It is not a matter of taking them out by a minimal access surgery and damaging the and nervous tracts and everything. So
Okay, now connecting with the operation theatre.
okay.
Patient is being anesthetized. Assalamualaikum.
Walaikum salam.
How are you, doctor? Please demonstrate the position of the patient and how we are going to mark
Okay.
our landmarks for us.
So the patient's been anesthetized, it's been positioned pro.
Zoom it out, please. First, let us see the whole patient and this position.
In beach going, huh? Zoom out for me. Okay, the patient's been anesthetized in position prone on pillows. We've just marked out the deformities with a permanent marker, and we're now just marking out the distal levels. I understand everyone had a discussion and decided on L23. My plan was actually L12, so it'd be interesting to have a discussion why we're going down to L23.
It was discussed in detail and three is the same because we are having a lot of growth there for balancing it will be okay for
L3. Yeah, I think my only concern with L12 would be to have enough room to put the domino in, so okay, fine. Okay.
Please demonstrate this picture if you are there.
Oh, my plan? Yeah, okay, so so I've just traced out the X-ray and I've put the markings for the implants here. So the proximal levels 2 and 3, a box there, and then the distal levels, I marked 1 and 2, but obviously we can go down to 3, but I think with the CV, I mean, I thought that was a stable vertebra, I have to say, but okay, so there's a box at the bottom, box at the top, and then we've got 2 apical pedicle screws on the convexity, and then there's going to be with some compression applied to them. They'll be joined to sliding dominoes on the convex side and the sliding domino on the concave side. So it's a self-growing system.
And
So we've got the
participants for management and
Which one will be her sliding one and which one will
okay. So is there anything else?
please indicate which rod is sliding and which rod is traveling.
Okay. So this is the sliding rod here, distally. This is a sliding rod as well. And this one, I was going to put a domino here as well, but this is a tethering rod here.
Well, it will connect, it will be one rod.
Yeah, so we connected it. It'll be,
Yeah, that's
Yeah.
right. And the other things that I would like to say that when we put the screw here, we can do it, since the child is a little bit having good body, we can have 3 small incisions, one proximal to put
Yes.
T3,
Yes.
one in the middle and one distal. And we can do it in this way and aim for having a big incision. This
Yes,
is
sir.
one thing. The other thing is that when we put the screws proximally and distally, we do the usual procedure, subperiosteal section, exposure, putting the screws. But in the convex side, when we put the tethering, it's demanding that we do it in some sort of a Wilson technique. So we see the longissmus, we go with our finger and just going medial to the longissmus and put the screw so as we don't do subperiosteal section, we don't irritate or damage the soft tissue, so as to have as much as possible a non-fusion technique, just putting the screws in this way. This is always in the apex we do that.
Okay, yeah.
So final to L3 lower instrumented. So lower instrumented vertebrae should be L3 and upper instrumented vertebrae should be at T2.
Yes, we've got T2 at the top, okay. I'll go down to, here we go, I'll change my plan, here we go. L3.
Yes. Any question from the participants?
Do you use a blocking screw to prevent the sliding rod to stop it from?
Usually on the convex side, you don't need it because it's already stiff, you know, the convex side is, but the concave, and you don't need to do distraction. On the concave side, when after doing the compression, translation, derotation of the convex side, we go on the concave side and do maximum distraction, and we put a buttress-like thing, just to prevent the sliding rod, whatever the sliding rod is. Actually, I think it's better to have the sliding rod, the thoracic one.
You think this is better to have it on the top side?
On the concave side.
Yes, this is the concave side, so
So I hope it will be the sliding rod there.
Yes, yes.
And so we put the buttress proximal to the domino.
So I was going to make this the sliding rod.
Well, if it's possible to get the thoracic one to be the sliding one, it's much better.
Is it? Okay, fine. All right.
Yeah, because you know we are always keen about the thoracic region more.
Okay.
So we put the buttress, exactly like that.
Yeah.
And you lock the buttress, not locking the domino, after you do a final distraction. Exactly. And you see here also, you can see that we need to have at least 4 centimeters after distraction of the rod. So potentially the patient will have 4 years of sliding rod without coming back to surgery.
Okay. So we'll just indicate that has to be
around 4
4
centimeters,
centimeters,
or more. But it's according to what we see. And this is a good thing that you can realize we are going to an area that can be covered by muscles and it's not prominent. This is very important, you know, especially not this kid, in very young kids, the domino is so much prominent, so we always have this problem. So sometimes with the domino, you can have a liberty to put the domino anywhere. Even this one, you can put it anywhere that can, but for the convex side, the rod on the convex side, the tethering rod shouldn't have anything below because it's not the one that will slide. The other one will slide, so you can do it in a way that you can have 4 centimeters also, but the domino is covered. It's an easy process. And because of that, maybe L3 can give you some space also to go and have a liberty to put the domino in safer place.
So this is going to be joined.
Yes.
And this is still going to be a sliding rod here though, but you're going to fit.
If the sliding rod would never, the tethered rod always locked. Always locked. The tethered one.
Always like this?
No. The tethered rod always locked. The sliding rod will be the number one. Because in all the time, whatever the tethering rod will be, it will be locked.
Well, on the concave, the domino will be loose on both the screws.
No, it will be loose here. Because of that, we'll have the bottom. But this will be locked. Because if both will be loose, it will not make anything.
Any other comments? Should we?
Any other question?
Sir, what about on the concave side?
Okay, you start your.
We'll start then, okay?
So you will start and see from the lumbar and put the lumbar screws.
Concave and concave side. This will be locked. This will be locked. This will be on this one.
Okay. Which part do you want to demonstrate?
Yes.
Yes.
We will demonstrate the pedicle screw. And at the last then we should demonstrate the apical screw insertion.
Okay.
After that we will rod then we will demonstrate.
Okay, fine. Okay, then, okay.
डोमिनो में 2 होते हैं ना सुराख, एक से ऊपर वाला आ रहा है, एक से नीचे वाला। जो कन्वेक्स साइड पे ना, उससे क्योंकि टेथरिंग रॉड ऊपर वाला है, ऊपर वाला आपका डोमिनो इस साइड पे लगा है, नीचे वाले को साइड में छोड़ इस साइड पे आपने ऊपर वाले को साइड में उसको डोमिनो लॉक करना है, उसको नीचे साइड पे।
So the other rod will be sliding.
हाँ ना।
Any tethered rod should be locked, period. So the other rod will be the sliding. On the concave side, it's preferable but not mandatory, preferable to have the thoracic rod to be the sliding one, so as to give a space for the thoracic region to grow much better. Because the thoracic region is the most important region, because it's the lung in these children. This is
Majid? Okay, now we'll continue with our lectures. Next lecture is from Dr. Arif Khan, neurofibromatosis, scoliosis. We really come across cases of scoliosis which having neurofibromatosis along with that. The cause is neurofibromatosis in that patients. We'll discuss that patient in care.
It's a terrible disease, and if you have one, you are in trouble. Okay, so thank you very much once again. So let's start with this patient who is a 16 years old boy. He presented with deformity and back pain. And what do you see in this picture?